Hello everyone, welcome to the chapter number 2, which is immunopathogenesis of the anaphylactic shock. So let's begin. In this chapter, we will explore the immunological chain of events that transform the allergen exposure into a life-threatening emergency, which is known as the anaphylactic shock. Anaphylaxis is a severe systemic manifestation of a type 1 hypersensitivity reaction. It is primarily driven by the IgE antibodies, mast cells, and the basophils, which result in a massive release of mediators that affect multiple organ systems. This is what we already know from our previous chapter. Now, IgE is an immunoglobulin which is responsible for the sensitization in the anaphylaxis. Upon the first exposure to an allergen, the antigen-presenting cells would stimulate the naive B cells to class switch and produce allergen-specific IgE antibodies. Those IgE molecules would bind to the receptors on the mast cells and basophils. They would sensitize them. On the re-exposure, the allergen would cross-link bound to IgE and would trigger the immediate cell activation. This is also something we already know from our previous chapter. The mast cells and the basophils are the primary effector cells of the anaphylactic shock, which is also known as the type 1 hypersensitivity reaction or the immediate hypersensitivity reaction. Now, these mast cells are abundant in the skin, in the respiratory mucosa, and in the gastrointestinal system. The basophils circulate in the blood and they would migrate to the inflamed tissues. When they are activated, they undergo the degranulation and release the potent inflammatory mediators. The activation of the mast cells lead to the explosive degranulation, which would release the histamine that causes vasodilation, increased vascular permeability, and the bronchoconstriction. And it would also result in the release of tryptase, which is a marker of the mast cell activation. It promotes tissue remodeling and further inflammation. And then there are leukotrienes, which are LTC4, LTD4, and LTE4. These are the potent bronchoconstrictors which would increase the vascular permeability and would prolong the inflammatory response. So what are the mediators that are released from the mast cells and the basophils? These are the histamines, the tryptase, and leukotrienes, and their altered function is bronchoconstriction, increase in the vascular permeability, vasodilation, tissue remodeling, and further inflammation. They also prolong the inflammatory response. The next thing is the systemic effects of the mast cells and basophil degranulation explain the clinical features of anaphylactic shock. So first of all, the vasodilation that was caused by histamines and the tryptase, it leads to the hypotension and warm flushed skin, which is often seen in the patients of the anaphylactic shock. So the next thing was increased vascular permeability. That will cause the plasma leakage into the tissue, resulting in edema of the tissues and the urticaria, which is seen in the anaphylactic shock patients. Another thing is also known as bronchoconstriction that results in wheezing, the shortness of breath, and the respiratory distress. Hence, all of those symptoms which are seen in the patients of the anaphylactic shock are the result of release of mediators by the mast cells and the basophils, and those mediators are there is histamine, there is tryptase, and then there are leukotrienes. To summarize all of this, the allergen exposure triggers the IgE sensitized mast cells and basophils. The degranulation would release the mediators like histamine, tryptase, and leukotrienes, and the systemic effects would include hypotension, edema of the tissues, airway constriction. Understanding this cascade is essential for the timely and effective intervention. Let's move on to the active recalls from this chapter. Question number 1 is, which immune cells are primarily responsible for initiating the mediator release in anaphylaxis? And the options are neutrophils, mast cells and basophils, macrophages, and T lymphocytes. And yes, we are very clear on this point that mast cells and basophils degranulation would cause all the mediators to release that would result in the symptoms seen in anaphylactic shock. So the answer is B. The next question is, which mediator is most responsible for increased vascular permeability in anaphylaxis? Now, if we recall it correctly, the options are interleukin 2, histamine, interferon gamma, and tumor necrosis factor alpha. And the answer is B, which is histamine. Three main mediators which are released from the mast cells and basophils during the anaphylactic shock are histamine, tryptase, and the leukotrienes. The next question is, tryptase is released predominantly from which kind of cells? So the option A is basophils, option B is neutrophils, option C is mast cells, and option D is B cells. And this question is quite confusing, but if you recall it correctly, the tryptase is released from the mast cells and would result in the symptoms of the anaphylactic shock. The next question is, which of the following is not typical of a systemic effect of mast cell mediator released in anaphylaxis? And the options are hypotension, wheezing, bradycardia, and urticaria. Now, if you recall all the symptoms which would present in a patient of an anaphylactic shock, we see the hypotension, we see there is shortness of breath, which is wheezing, we see there are skin symptoms which result in urticaria, but we don't see the bradycardia. I have also included some case-based questions from this chapter. So for example, you have seen a patient who is 22-year-old male and he eats a peanut protein bar, and within minutes he would develop a generalized urticaria. There is shortness of breath and there is dizziness. Now, as soon as you see a patient who has presented with urticaria, shortness of breath, and something related to the nervous system, right after, like within seconds to minutes after the exposure to some kind of allergen, you would recognize it as a case of anaphylactic shock. You also measured his BP that came out to be 80 by 50 mm of Hg. His respiratory rate is 28 per minute with the audible wheeze which could be listened. So, which immunological mechanism best explains this condition? You have to answer this. The next case-based question is, a patient experiences recurrent wheezing and urticaria after the bee stings. Serum tryptase is elevated during the acute attacks. And what is the significance of the serum tryptase in this scenario? So, as you already know, tryptase is a mediator which is released by the mast cells during the degranulation procedure in the anaphylactic immunopathology. It is a reliable biomarker of the mast cell degranulation, and it supports the diagnosis of the anaphylactic shock. That's it from our side. We will see you in the next chapter very, very soon.